All right. So when PK asked me to give this talk, I thought maybe he didn't like me very much, but but I'm ready to take it. So, so the obviously the title is common femoral artery intervention. It's ready for endovascular therapy. It's ready for prime time. These are my disclosures. And so when we look at this too, it's a little bit of looking at endovascular approaches with the common femoral artery, which has historically been a surgical only space. But is endarterectomy the gold standard? And I think my colleagues here, and Dr. McKinsey will also talk about this as well too, that obviously CFE is really an excellent procedure, and I do believe that as well too. I think it's excellent patency. When we think about the groin, there's a lot of crush forces, the flexion point. Heavy calcium makes things very challenging, as you've already seen. And involvement in the bifurcation obviously makes things problematic, especially from an endovascular approach. What are the cons? I mean, the patients are not always clean cut. And, I live and work in Florida where we have very overweight patients who are diabetic with end-stage renal disease who they're all walking around with EFs less than 15 to 20%. These comorbid patients obviously have higher surgical risk in general. You may argue you're able to get away with minimally invasive procedures, but even then there are other issues as well as healing issues, complications that can occur just from the surgery itself. And what we've also seen too as well, a lot of these meetings you'll hear about the best practices when it comes to performing endarterectomy, but clearly there are a lot of different ways people do the procedure, and there are differences which may lead to differences in patency as well too. Whether or not people use patch angioplasty techniques, which is not consistently done, eversion techniques versus using a bypass versus just very simple endarterectomy. And unfortunately, just pulling the plaque out may not always be sufficient for some of these patients. So why is endo potentially beneficial? Obviously, early recovery. Patients with hostile groins, it may be favorable for an endovascular approach. You can do R2P, you can do a pedal approach. You can always potentially leave options open for surgery later on. And also you can address both the inflow and the outflow lesions. If you have an iliac lesion as well too, obviously from a surgical approach, going after that at the time of doing your endarterectomy is challenging, and sometimes hybrid procedures are necessary. What are the cons? We've talked about this as well too. Is there potentially less patency, a fracturing of the stents themselves? Heavy calcium can be a challenge with scaffolds, and we saw also size can be an issue as well. If you have the bifurcation involved, it may involve retro techniques, direct profunda puncture. We've certainly seen plenty of folks, and my surgical colleagues have also seen these nightmare situations where people have stented across the profunda, and then the profunda is the lifeline to the legs. So doing that is obviously not an ideal situation, despite there are advocates in the literature saying that even with supera stents you can jail the profunda and get away with it. But we have limited data. And dissections may be a problem, and there may be a higher rate of re-interventions on these patients as well too. So I'm not really selling endo right now, but I think there's a lot of differences with regards to technology. And so just so we have the same definitions, this is what's been used in the past, the Azima classification with regard to what does this lesion look like. And the lesion that we just saw really was an Azima 2 because it's isolated just to the common femoral artery. If it involves both the profunda or the SFA, it's a 3. Now, class 4 are grafts patients. We're not going to talk about those. Those are patients with anastomotic lesions. And then type 1 includes inflow as well, too, in the iliacs. But there's a newer classification, Rebellina, which actually is more appropriate for us to kind of describe these kind of patients. And it takes that class 4 and changes it to look as whether or not these patients have involvement of the profunda and also the SFA. And then it also further characterize it based on location stenosis and calcification. Is it stenotic? Is it occlusive? Is there mild to moderate calcification, or is there severe or heavy calcification as well? And this can be helpful when we're talking about these lesions, and also to try to define which patients may potentially benefit from an endovascular approach. This was a retrospective study done by the Japanese, and they looked at their surgical patients and also their endovascular patients, and they found that patients with nodular calcification had the highest hazard ratio with regards to endovascular therapy. So it seems like thromboendarterectomy was superior in that population. The patients that were non-ambulatory really was equivalent between both groups. But really, when they looked at their endovascular subgroup analysis, the patients that did the best, had the lowest hazard ratio, are those that actually had scaffolds placed. So just doing DCB alone or POBA really, unfortunately, did not have great results. But there was a randomized trial that was done, published not that long ago, the TECO trial. 117 patients come from a disease randomized to endarterectomy versus stenting. And they actually used self-expanding stents in the column femoris and then balloon expandable stents in the ostomy, the SFA, or the profunda when necessary. And they found that endarterectomy had higher rates of morbidity and mortality at 30 days, 26% versus 12.5%, so odds ratio of 2.5. So there was more issues of delayed healing, paresthesias, hematoma, infections. Also, hospitalization was longer in the endarterectomy group. And at 24 months, they found no differences with regards to clinical improvement between both arms. So both were equivalent with regards to patency or TLR. So this comes into the discussion about biomimetic scaffolds. And so what are the advantages of these biomimetic scaffolds with Supera, more radial compressive force with low axial stiffness, which allows for the flexibility while maintaining that outward force in those calcific lesions. And they've also advocated, especially in Europe, reaccessing through the struts to go after side branches and also potentially be able to do other interventions. There's also this newer Biomimics 3D stent. We were in their trial. Easier to deploy than Supera, but has perhaps less radial compressive force, and there's very limited data within the common femoral segment. Dr. Deleuze, who you may all be familiar with, had talked about his initial data in the VMI CFI's multicenter single-arm study where they looked at edema 2 and 3 lesions and found primary patency at 1 year at 95% and then 93% at 2 years. And this informed the development of the SuperSURGE study, which is currently enrolling in Europe, where they're looking at common femoral stenting versus endarterectomy, randomized 1-to-1, and again, those same type of lesions. But they don't incorporate atherectomy or thrombectomy, and they're looking at primary patency after 36 months. So, it's going to be an interesting thing to see the results of these, but there are a number of technologies that we have, including IVL, thrombectomy, and also debulking atherectomy that's really not been looked at. And so this is where I think there needs to be a potential development and a further study as well too, even potentially use of TAC for dissections that can occur after an endovascular approach, and bioresorbable scaffolds. Early experience with this was poor, but some of the newer bioresorbable scaffolds that are coming up on the market may be potentially beneficial within this space. So I'm going to just show 3 quick case examples in the remaining time. This is a patient, CLI, diabetic, advanced CKD. I used CO2 for this entire case. And so this is an edema 3 or Rabellino 3. So she's got stenosis of the SFA and a heavy amount of calcification. So in this case, I did a combination of laser atherectomy because the IVUS informed me that it was eccentric, and then also intravascular lithotripsy due to the residual calcium that was there. I didn't show the intermediate angio because I wanted to limit my contrast. So this is what we call laser shock, and I've used this very sparingly, typically for these common femoral lesions. And after this, we used drug-coated balloon. So a very expensive case, but you can see afterwards the results are pretty reasonable, and the patient had very good flow with no embolization. In all these cases, we do put a filter down as well too. This is another patient with a hostile groin, CLI patient, edema 3, Rabellino 4. So involvement of the profunda and the SFA. With this whole case was done via a combination of R2P and also pedal. So we did R2P just for imaging. We couldn't really access the groin, so we came from the foot. And in this particular case, this is I show this because we did a atherectomy here, scoring balloon with DCB afterwards, and look what happened. So we lost the profunda when we did that. So quickly, I went ahead and got access back into the profunda. You can see I'm going up and over here. I've got a navicross down. I show that I've got patent flow there. And then across this, I ended up doing scoring and also DCB to restore flow into the profunda with fairly nice results. And this patient has remained open now over 6 months so far. That last case, patient with BKA with a stump wound, now immobile, dialysis patient, Rabellino 3. So heavy calcium that you can see, and there's also involvement of the profunda, rather the SFA ostium as well. So in this particular case, we used IVL alone and then did DCB afterwards. And you can see we did have a little dissection of the ostium of the SFA, so we placed 2 tacks at the ostium of the SFA. So this is the original study, and this patient, one of my vascular surgery colleagues took her back before he did a revision of her stump. This is 12 months later, and you can see that the angiogram shows fairly reasonable results without significant progression from what we did before. So endarterectomy is possible. It can be done in select cases. I think if there's involvement of the bifurcation, both profunda and the SFA, you have to think about really hard whether or not you want to do an endo-only approach. But obviously the use of these newer technologies may allow for improved outcomes. Thank you.